have conditions like jet lag, deep venous thrombosis, pulmonary embolism. I'll discuss this in detail shortly. And then sea travel, seasickness, how to avoid it, how to prevent it, and finally, travel by road traffic accidents. Environmental hazards according to destination. You may be going to a country which is very humid, very hot. So in that case, you need sun protection. If you don't have, or if you don't use this sun protection, extreme heat and cold can lead to dehydration, can lead to heat stroke. So always have plan from before as to how you will avoid such situations. If you're going to a place where there is a lot of heights like Nepal, Mount Everest, or K2 in Pakistan, northern areas, or the Alps in France, hypothermia, frostbite can take place if necessary preventive measures have not been taken. And if you're planning as a traveler for water recreation, you have to be careful regarding drowning, boating accidents, diving accidents, and swimming in ponds, rivers, streams can lead to risks like schistosomiasis and leptospirosis. So all this information has to be given to the traveler once you are having a head-on meeting with him. Sun protection. Travelers should apply sunscreens for protection from sun exposure. It is to be applied in sufficient quantity to achieve proper protection. And if sun exposure is for a long time, for an ongoing duration, sunscreens should be applied, reapplied at 2 hours interval. After swimming or profuse sweating also, it is recommended that sunscreens should be used, otherwise there can be skin damage and skin burns. I will now discuss motion sickness. Medications to prevent motion sickness are best taken prior to beginning a journey. They are of little benefit if you have already started your journey and nausea and vomiting has already started. I think they are of little benefit. This has to be informed to the traveler in advance that better to take this medication before you start your journey. For long-term control, such as might be needed in case of a sailing expedition or when frequent bus trips are taken, sustained release transdermal scopolamine may be applied. Scopolamine may cause drowsiness though, and drying of the mucous membrane. However, it is very, very effective. Phenergan may be taken, but the problem with Phenergan is that it causes high sedation. If scopolamine and Phenergan is not available, metoclopramide or any drug that can, any tablet, any medicine that can help you in this nausea can be taken. Now I will come to jet lag. I think for our current means of transport, jet travel, air travel is the most common one, and the passengers generally face this problem of jet lag. So what is jet lag, first of all? Jet lag is associated with travel across multiple time zones, usually more than 5 time zones. It occurs because of the normal circadian rhythm is disrupted. It is characterized by symptoms of fatigue, impaired sleep, loss of concentration, and impaired performance. So basically, fatigue is there, sleep pattern will be disturbed, the patient or the traveler may complain of loss of concentration, difficulty in balance, impaired performance. So basically, the main issue is fatigue. Some individuals report additional symptoms such as heartbeat irregularities and increased susceptibility to illness. Generally, travel eastward is associated with more symptoms and take longer to adapt. Treatment of jet lag is that short-acting hypnotics and melatonin have good results. Basically, in short, if you want to get rid of your jet lag, try to have a good and sound sleep. The more you sleep, 3 to 4 hours, 5 hours of sound sleep will immediately give you excellent results. If hypnotics such as benzodiazepines are used, they should be tried before travel and taken in the lowest effective dose, because obviously they can lead to sedation. They may be taken for the first few nights in the new zone and may help to alleviate the exhaustion from failure to sleep. So basically, the treatment of jet lag, as I mentioned, is that the traveler needs to take a sound sleep for at least 3, 4, 5 hours, and immediately he will feel much better. How to prevent jet lag before travel? The best thing is to exercise, eat a healthful diet, and get plenty of rest. A few days before you leave, start going to bed an hour or two later than usual before traveling west, or earlier than usual before traveling towards east to shift your body's clock. Break up a long trip with a short stop in the middle if possible. Now, this all depends upon how much time the traveler has, but if he can manage all of these things, it will really be very, very helpful to avoid jet lag for him. What can be done during travel to avoid jet lag? The best thing is to avoid large meals. Obviously, alcohol should not be taken. Caffeine, if taken in large quantities, can have insomnia, so better to be avoided also, or to be used in little quantity. Drinking plenty of water will always be helpful. On long flights, get up and walk around periodically. Sleep on the plane if you can. So these things will also help to alleviate the signs and symptoms of jet lag. After you have arrived, don't make any important decisions on the first day. Though it's easier said than done, you may have a meeting on the very first day of your arrival. But if it is possible, it's better to take a rest on the first day. Eat meals at the appropriate local time. Spend time in the sun. Drink plenty of water and avoid excess alcohol or caffeine. If you are sleepy during the day, take short naps for only 20 to 30 minutes so that you can sleep well at nighttime. Other risk factors, as I mentioned, alcohol remains a major cause. Stay away from alcohol, both for the occurrence of accidents and injuries and for engaging in unsafe sexual practices. Use of alcohol or illegal substances may increase the risk of assault or arrest. Obviously, if the person is not completely in his senses, is drowsy, there is always a possibility of assault as well as police action, depending upon the rules and regulations and policies of that country that you are visiting. Because of the risk of acquiring sexually transmitted infections, including HIV, from sexual experience overseas, travelers should either abstain or use barrier protection. We'll be discussing in detail sexually transmitted infections in the coming lectures. Travelers need to be aware of the risks of blood-borne infections, especially HIV, hepatitis B and C, from unprotected sexual contacts and use of contaminated needles. Vector precautions are very important, depending again on the country that you are going in. If you are going to a country where malaria or dengue fever or yellow fever is endemic, it's always good that you need to cover the exposed parts of your skin. Treatment of outer clothing with permethrin is always helpful. Use of permethrin impregnated bed net is again a safe way of sleeping. There's no possibility of getting bitten by a mosquito in that case. Use of insect screens over open windows, preferably if you are sleeping in a room which is air conditioned, is always good. Use of aerosol insecticide indoors, and inspection for ticks, use of perathroid coils outdoors. All these measures can be taken, or any one of them can be taken to avoid mosquito bite and tick bite. Here I show you just a photo of mosquito net vector precautions, and I've shown you a photo of repellents, especially being used on the exposed parts of the body, especially if you are walking in a jungle area. Now I come to venous thromboembolism precautions. What are essentials to be done? Here is a study which had very clear results that longer the distance that you travel, more is the chance of, or the possibility of, the probability of having deep venous thrombosis or a pulmonary embolism. As you can see, if the distance is more than 10,000 kilometers, more the distance, more the possibility of having embolism as well as DVT. I've already mentioned the precautions that need to be taken. If the distance is more, you need to walk, whatever little walk you can do within the aircraft or train that you are traveling in. Okay, travel-related long journeys more than 4 hours by plane, train, bus, car, etc., are thought to cause an increased risk of deep venous thrombosis. This is probably due to sitting immobile and cramped for long periods. The economy class syndrome, as we call it. Blood flows more slowly and collects in the legs when they are hanging down. Blood flowing slowly is more likely to make clots. So even if you're sitting, you can just move your legs up and down a little bit. You can move your feet up and down a little bit. You can give them lateral movement, medial movement, and even this is enough. As we all know, our calf muscles, the gastrocnemius is also known as the peripheral heart. The more you move your legs a little bit, the blood flow, the blood pooling down in your legs can just go upwards, and this can be of tremendous help to avoid embolism and deep venous thrombosis. Preventive measures include avoiding prolonged immobility, not wearing constrictive clothing around your waist, exercising calf muscles, maintaining hydration, and limiting alcohol ingestion. The other very important point here is hydration. You need to drink water, a lot of it. And just keep moving your legs a little bit, your arms a little bit, whatever you can do without causing problem to the person sitting next to you, obviously. The use of below the knee stocking and low molecular weight heparin may decrease the incidence of DVT among high-risk travelers. Now, there are those who are at high risk. Who are these people? Anyone may develop a DVT following a long journey, but the following have an increased chance and increased risk of developing DVT. Who are these people? Having those who had an operation in the previous 2 months. Pregnant ladies, there is a more possibility for them to have DVT. Having had a DVT or pulmonary embolism before, past history of DVT. Having a close relative who has had a DVT or pulmonary embolism in case there is a family history. If the traveler is very tall or very short, also the possibility is higher. Cancer patients, travelers who have blood clotting disorders, travelers who have a broken leg and are using a POP, a plaster, recent severe illness such as pneumonia, heart failure, or heart attack. All such travelers are more likely to have DVT, and that is why they must be educated that how important it is for them to remain mobile, or at least even if they are sitting, to move their legs and arms a little bit after every 15 to 20 minutes, half an hour. What else can reduce the risk of travel-related deep vein thrombosis? Exercise, as I've already mentioned, drinking a lot of water, do not drink much alcohol, do not take sleeping tablets, because obviously if the traveler is taking a lot of sleeping tablets, he will be sleeping and he will be immobile. Elastic compression stockings are always very helpful. Now I will discuss the high altitude illness, especially mountaineers, those who love mountains and go to the northern areas towards Nepal, especially. Travelers going to areas, to destinations more than 2,500 to 3,500 meters carries the risk of altitude. So this category, these type is divided into 3 syndromes. The first one is the acute mountain sickness, AMS. This will be characterized by symptoms like headache, anorexia, fatigue, dizziness, and sleep disorders. This initial condition is known as acute mountain sickness. If still the traveler intends to go to more heights, it can lead to high altitude cerebral edema, HACE. This is characterized by poor concentration and lethargy, progressing to ataxia, altered consciousness, and coma, with death resulting from brain herniation. The last one is high altitude pulmonary edema, also known as HAPE, is heralded by dry cough, shortness of breath with exertion, progressing to shortness of breath at rest, and production of pink froth sputum as pulmonary edema occurs. These are all very serious conditions. How we can avoid it, I will be discussing it shortly now. Travelers with underlying cardiac, pulmonary, or hematologic disease should be carefully evaluated for their ability to travel safely to high altitude areas. So high altitude areas, mountains may look very beautiful, but they can be dangerous also. And this information needs to be passed on to the traveler. How to prevent it? Acclimatization is very, very important. Acclimatize yourself. Don't go to more higher areas in one go. Acclimatize yourself. For example, if you are at 1,000 meter height, stay there for the night. Then move on gradually. Spending a few days at an intermediate altitude of 3,000 plus meters will acclimatize you, your lungs with the oxygen level there. For every 1,000 meter ascended, an extra night should be spent at the same elevation. So first of all, educate your traveler regarding the importance of acclimatization. Apart from that, acetazolamide, a carbonic anhydrase inhibitor, facilitates acclimatization by increasing ventilation, increasing bicarbonate diuresis, following respiratory alkalosis at altitudes, and increasing arterial oxygen levels. 125 to 250 milligram twice daily is the dose for acetazolamide, begun 1 day before ascent and continued at least 2 days at the highest altitude. Those travelers using it may experience finger paresthesis and mild diuresis. Dexamethasone can also be used, but it is reserved for treatment of severe cases of altitude illness. So the travelers can keep these medicines with them if they are especially going to high altitude areas. In the absence of improvement, the first response should be descent. Sometimes a descent of as little as 500 to 1,000 meters may be life-saving. Now, this is again a very, very important point that needs to be educated, needs to be given to the traveler. That if he or she starts developing problem despite acclimatization, the best option for him or her is to descend, to just go down. Don't go any more further, even don't prefer to stay there, rather go down. Descent can save lives. As I mentioned here, just a descent of 500 to 1,000 meters can be very, very helpful and beneficial for the traveler. Although oxygen, hyperbaric chambers, acetazolamide, and dexamethasone have been used for various conditions, however, none of these are as important as descent is. I thank you all for your patience and for listening to this lecture. I hope it was beneficial. And now we are open to if there are any questions, please.
Thank you a lot, Dr. Baber, for this informative lecture. You really shine the light on the most important travel-related health problem and environmental hazard which may face the traveler during their journey. And also you shine the light on the measure which we can follow to avoid and decrease the incidence of this travel-related health problem. Thanks a lot, Dr. Baber. Now I think I will open the floor for any question. Please, if you have, my great audience, if you have any question for Dr. Baber, please feel free to ask using the question and answer box. Any question for Dr. Baber? We will give them a couple of 2 minutes, Dr. Baber. If there is no question, we will proceed.
Sure, Dr. Arwa, please. Thank you very much. Let's move on if there is no question, please. Thank you.
Ali, there is a question from Ali Sharik. Ali Sharik, can you repeat your question again? It is not clear. Here it is written kindly. Can you tell why you said that walk to Eastern in the morning? Ali Sharik, can you repeat your question? We couldn't detect your points. Please, if you have any question, feel free to ask.
Dr. Arwa, I can explain this point further, because if you are going against the time, if you are going opposite to the flow of the circle, So in that case, you will take more time to adapt. For example, if I am from Saudi Arabia traveling towards Pakistan or India or towards Bangladesh, so I'm going in the flow of the time. Okay, they are 2 hours ahead of us, so I will take lesser time to adapt. But if I'm going in the backward direction towards Europe or towards Africa, I may take more time to adapt. This is what I meant. I hope it's clear now.
Clear, Dr. Babu, thank you. I have another question from Ali. Okay,
Yes,
I think
please.
10 question. Kindly, can you briefly that to break circadian rhythm? Why you said to move to East? I think he repeated the question.
Yes, the circadian rhythm, Dr. Aroa, is the same that I'm talking about. If you're traveling against the time or you're traveling with the flow of the time. If from Saudi Arabia, you're traveling towards South Asia, Southeast Asia, towards Indonesia and Bali, you are traveling in the direction of time. But if you're going backwards, which is towards Africa and towards Europe, you are traveling against the flow of the world or the flow of the time. And that is why it will take you more time to adapt.
Great. Thanks a lot, Dr. Babu.
Thank you, Dr. Aroa.
Thank you. I think we will proceed, inshallah, with our next speaker, Dr. Safa Al-Wakil. Dr. Safa Al-Wakil is a public health and preventive and community medicine physician. Welcome, Dr. Safa. She will present to us, inshallah, regarding the immunization specific for travelers. Dr. Safa, are you with us?
Yes. Is my voice is clear? Hello?
Yes, your voice is clear, Dr. Safa, but please share your screen.
Okay. Is the screen up here?
Yes, Doctor, it is clear now.
Okay. Yeah. Let us go about vaccine and the travel, or travel, vaccine and immunization. All of us now know the magic rule of the immunization, especially with the COVID outbreak. So the important point of this lecture to know about what is the vaccine recommended if we want to travel anywhere. Vaccine is one of the great public health achievements of the human history. Immunization is one of the most successful and cost-effective public health intervention. We see that carefully clear on the COVID outbreak, not only a cost-effective, but a save life. Each year, vaccine prevent 2 to 3 million deaths every year, and the additional 1 million deaths can be avoided. However, if global vaccination coverage improves. We talk now about what is the difference between the routine required and recommended vaccine, and what vaccine do I need before I travel. Routine vaccine. Please write on the chat about what we mean with routine vaccine. If anyone know what we mean about the routine vaccine.
Your participation is highly appreciated. Anyone want to participate? Here is one answer, Dr. Safa. Dr. Ahmad answering influenza vaccine.
Mm-hmm. Anyone know about what is the routine vaccine?
Dr. Safa, here there is some answers. Dr. Ahmad mentioned influenza vaccine. Kamil Ali mentioned typhoid vaccine.
Mm-hmm. Okay.
DKB, meningococcal vaccine. This is the given answer.
Okay, so we talk now about the routine vaccine means that's recommended for everyone based on their age, health condition, and other risk factor. Most people think of this a childhood vaccine that you get before starting school, but there is also routine vaccine for adolescent and adult, and some are recommended every year, like we said now about the flu vaccine, or every 10 years as a booster for adult. Ministry of Health now updated the card of the vaccine, which included the routine and the essential vaccine and also the adult vaccine. Immunization for adult traveler, routine vaccine, which there is a list of the routine vaccine now. The head on the head COVID-19 and also varicella, hepatitis B, hepatitis A, human papilloma virus, influenza, measles, mumps, rubella, meningitis. All this vaccine is included routine vaccine, travel-related, hepatitis A, hepatitis B, typhoid, rabies, meningococcal diseases, polio, Japanese encephalitis, yellow fever. This is the card of the immunization at KSA. We see now this is the basic essential immunization in different age. And also on the back of this card, we see the adult vaccine. So that is the routine vaccine. Required vaccine is a vaccine one of the traveler must have in order to enter a country, based on the country governmental regulation. COVID-19 vaccine, yellow fever, travel going to Mecca for Hajj need also specific immunization. Can anyone write what is the vaccine must take before going to Mecca for Hajj?
The answer is MCV, pneumococcal, meningococcal, influenza vaccine.
Okay. The mandatory for going to Hajj, it is influenza and meningococcal vaccine. Vaccine required is the country attempt to keep traveler from bringing the virus or the disease into the country. Vaccine required can change at any time because the country governmental could control this decision. Recommended vaccine are those the CDC recommended travels got to protect their health even though they are not required for entry by the government of the country you are visiting. Recommended vaccine are not part of the routine vaccine. They protect the travelers from illness that are usually travel related. COVID-19 vaccine, now we must have approved for this, and there is many doses for the vaccine. And now we the announce about the fourth dose. And tomorrow there is a lecture about the COVID virus and travel. Vaccination for most traveler diseases associated with poor hygiene and sanitation, like hepatitis A and typhoid. Traveler at special risks according to the geographical risk or risk because the age, pre-existing condition or occupation, like a food handler or a health care worker. Geographical risk as a vector-borne disease, yellow fever, Japanese encephalitis, tick-borne encephalitis, wilderness remote travel, rabies, TB, current epidemic, cholera and plague. Yellow fever zone, there is a 2 zone for the yellow fever. One in Africa and the other one is America. And the yellow fever vaccine is a live vaccine containing weakened live yellow fever virus. It is given as a single subcutaneous or intramuscular injection, 1 dose of 0.5 milli. Vaccine is a single dose vaccine recommended for the traveler to the certain part of the South America and Africa, administered at least 10 days before planned arrival. This is an international country requirement. Patients should also be advised to carrying proof for vaccination as a yellow card when traveling to the certain destinations that require the yellow fever vaccine for entry. The vaccine lasted for life for most of the people, but in some cases, which is an impaired immunity, need a booster after 10 years. And the recommendation to don't donate blood for 14 days after the vaccine, because there is a risk for passing vaccine virus to others during that period. The recommended thing is about the vaccine also, we must write all about the vaccine, the contraindication, and when we give the vaccine, we must be sure that we keep the vaccine in the recommended range of temperature to keep the vaccine in most effective way. And read about all the contraindication about the vaccine. Most of the contraindication for all the vaccine, it is the general contraindication, is the history of acute hypersensitivity reaction to the previous dose of this vaccine, and also is we have a hypersensitivity reaction for any component which included in this vaccine. So at the yellow fever, allergy to the vaccine component, including gelatin, egg product, or chicken protein, thymus disorder, immunosuppression for the following, because the yellow fever vaccine, it is the live vaccine, so the contraindication for every live vaccine, if there is an immunosuppression, symptomatic HIV, which is the CDC cell blue 15% or blue 200 over MM3, malignant neoplasm, primary immunodeficiency, transplantation, immunosuppression or immunomodular therapy, radiation therapy, infant less than 6 months, pregnant or breastfeeding, transplantation within 2 years of transplant. The precaution, it is a period after the recommended age of the giving the vaccine, aged 6 to 8 months, age over 60, asymptomatic HIV, even the CDC CD4 cell, 15 to 24% or 200 to 499 over millimeter square cubes. Typhoid vaccine. Vaccine of typhoid, there is a 2 vaccine for typhoid fever, one oral and one injectable, recommended for the traveler going to the country that is endemic for typhoid. Administration of the injected vaccine at least 2 weeks before travel, completed for those for oral vaccine taken 2 days apart, at least 10 days before travel. The inactivated injectable vaccine lasting 2 to 3 years. That is the information about the inactivated typhoid vaccine. It is given to people 2 years and older. 1 dose is recommended at least 2 weeks before travel. Repeated doses are recommended every 2 years for people who remain at risk. A lice typhoid vaccine is administered orally. It may be given to the people 6 years and older. One capsule is taken every other day. For the total 4 capsules, the last dose should be taken at least 1 week before travel. Each capsule should be swollen whole, not showed, about an hour before meal with cold and or lukewarm water. A booster vaccine is needed every 5 years for people. Typhoid fever vaccine indication: travel to the endemic area, adventure traveler, travel for more than 3 weeks, rural travel. Neither the typhoid pills or shot offer complete protection against infection. The efficacy of this vaccine is about 50 to 80%. And both lose effectiveness over the time. So the regulation or the recommendation that said about careful at the other lecture of Dr. Swar, it is important point for preventing this disease. Contraindication has an allergy reaction after a previous dose of the typhoid vaccine, or has any severe life-threatening allergy, has a weakened immune system, is pregnant or breastfeeding or thinking to might be pregnant, taking or has recently taken antibiotic and anti-malarial drug. And this point we will talk. Yes?
Here is one comment. You are so fast. Can you slow down a little bit, please?
Okay. This point about taking antibiotic and anti-malarial with typhoid vaccine, we will talk about it later on. Hepatitis A vaccine. Most adults have not been vaccinated against hepatitis A vaccine. It introduced to the essential immunization card recently for all the children. If we take the hepatitis A vaccine, we must take a 2-dose, 6 months interval. At least 1 dose should be given before travel. Effectiveness is a little as 2 weeks period to the travel. So we must give the vaccine even we live in less than 2 weeks. The first dose give 95% protection, and the 2 dose give 99%, inshallah. Hepatitis B vaccine. Hepatitis B, it is an important vaccine, especially when traveling to the country with the hepatitis B prevalence more than or equal to 2%. The prevalence of this disease means number of the cases who tested positive for hepatitis B antigen multiply 100,000 over the population estimate. There is a 2 schedule for hepatitis B vaccine. The normal schedule is a 3 doses vaccine that is recommended for all non-immune traveler, especially those who are traveling to the country with a prevalence more than 2%. Administrated doses is a 0, 1, and 6 months for the Energic B and the Recom BVAC hepatitis B and Twinrix. This is the type of some vaccine. And giving the 3rd dose should be more than 2 months after the 2nd dose, and more than or equal 4 months after the 1st dose. And the regular table is the 0, 1, and 6 for the 3 doses hepatitis B vaccine. And there is an accelerated schedule for this vaccine is a 2 dose, and this is given for the adolescent or the old adult The interval between the first and the second dose must be equal or more than 1 month. Meningococcal vaccine. It is an important vaccine recommended for the traveler to the area of the meningitis belt, which we saw in the picture here. The meningococcal belt, sub-Saharan Africa, particularly during the dry season, December through June. When the disease is more common, it is required for the traveler to Saudi Arabia for the Hajj, administered at least 10 days before travel, and recommended revaccination every 5 years. Less commonly used vaccine, Japanese encephalitis, an important mosquito-borne disease in Southeast East Asia and East Asia. Those staying in high-risk area for long period of time should consider it. It is potentially lethal disease. And this is the geographical area of the Japanese encephalitis. The vaccine is a 2-dose recommended for the certain traveler to Asia and the Western Pacific, including long-term traveler, a trip lasting more than or equal 1 month to the endemic area during rainy season. Consider for the following group: short-term, less than 1 month traveler to the endemic area during the Japanese encephalitis virus transmission season. If there is actually and activated, increase their risk. Especially there is a spending outdoor in the rural or agriculture area. Traveler to an area with an ongoing outbreak of the Japanese encephalitis, a traveler to the endemic area who are uncertain for a specific activity or duration of travel. Administrative doses, 2 doses, at 0 and 28 days. The interval between the 2 doses is 28 days, or there is an accelerated schedule of doses 0 and 7 days, has been approved from CDC. Ideally, complete the vaccine series at least 1 week before the travel. This vaccine approved since 2009. It is making from the monkey kidney derived cell culture inactivated vaccine for those more than 17 years. Approved to give 2 doses series. The interval between the 2 doses is 28 days. Cholera vaccine, routine used for cholera vaccine is not recommended as risk is low, but it is indicated for the travelers to cholera endemic area who are at risk, who are at high risk for infection, 2 to 3 years protection. Administered at least 10 days before travel. That is malaria vaccine, or the area of the chloroquine resistant malaria. Vaccine of malaria consider malaria prophylactic for traveler to the area with malaria transmission, which included part of Africa, Latin America, part of the Caribbean, South Asia, East Asia, Middle East, Eastern Europe, and South Pacific. Choosing a medication for prophylaxis must take into consideration, into account that the traveler medical history and the current medication, as well as malaria drug resistant in the area of travel. Routine non-traveler vaccine or booster before travel, including influenza, measles, mumps, and rubella, tetanus, or the other vaccine which included tetanus, like TD or Tdap, varicella, pneumonia, and polio. And there is a memo for giving a polio for the person who traveled to the Philippines. This is a point we talk about the antibacterial, antiviral. There is no contraindication for giving a vaccine or a regular vaccine when we're taking antibacterial, especially if it is an inactivated vaccine. The antibiotic doesn't have an effort on the has an effect on the immune response to the most of the vaccine. But with oral typhoid, shouldn't be administered to person receiving sulfonamide or other antibiotic. So we must stop this antibiotic at least 72 hours. Then we give the vaccine. And also with the varicella containing vaccine, antiviral drug against herpes virus as a cyclovir and the other antiviral vaccine should be discontinued 24 hours before administration of the varicella containing vaccine if possible. We talk now about some contraindication of the specific vaccine, like DBT or Tdap. For the brainstorm, anyone know what is the difference between the Tdap and DBT? DBT, which is all the letter is capital. Tdap, the letter D is small. Anyone give up?
Here there is an answer here. Tdap given for adults. And Sarah Itani answering DTaP is the first we give.
Excellent. Tdap is the vaccine for adults because letter D means a small amount of this vaccine, including in this combined vaccine, which approved for giving to the adult. So the contraindication of this vaccine, the post vaccine, is like any other vaccine, severe allergic reaction for the previous dose. For pertussis containing vaccine, encephalopathy, coma, decrease the level of the consciousness, prolonged seizure, causes within 7 days of administration of the previous doses of DTB or DTaP or Tdap or any other vaccine, including the pertussis vaccine. That is a contraindication. So and the precaution, like Guillain-Barré syndrome, progressive or unstable neurological disorder, including infantile spasm, uncontrolled seizure, or progressive encephalopathy until the treatment regime has been established and the condition has stabilized. And also the temperature increase, because this vaccine will be increase the temperature. So we must be careful about this condition. Contraindication of the oral polio. any state of the immunosuppression, or any household contact who are immunocompromised. In this case, we must change the oral polio to the injected polio vaccine. Contraindication of the influenza vaccine, moderate to severe disease, anaphylactic to the previous dose, and age less than 6 weeks. Sorry, this 6 months, because the influenza vaccine is recommended after 6 months. MMR contraindication, severe allergic reaction to the previous dose, and also this MMR is a live vaccine. So it is a contraindication in an immunodeficiency patient and pregnancy and with neomycin allergy. And the precaution when taking antibody containing blood product, and we have a list for this interval, history of the thrombocytopenia or thrombocytopenia purpura, need for tuberculin skin test, and we have a slide about it. MMR and the tuberculin test. Anyone give us a hint if we can give an MMR and the tuberculin in the same visit, or the regulation we can use when we wanted to make both?
Ali is answering here. Ali Sharaf, his answer in a different visit.
What?
In a different visit, another answer must be given separately. The different visits.
Okay. We here have a 3 options. The first one, we can make it on the same visit, or perform a BBD test, then after 3 days, when we give the result, give an MMR, or give an MMR, then perform a BBD after 4 weeks. So we have a 3 options for making them. The first choice is giving them on the same visit, perform a BBD test, then after 3 days, after we taking the result, give an MMR, or give an MMR, then perform a BBD test after 4 weeks. Varicella vaccine, the same, it is a live vaccine, so contraindication for the severe allergic reaction after a previous dose, or a non-severe immunodeficiency, patient with HIV infection and pregnancy, precaution with blood transfusion and receiving a specific antiviral, which we talking about it on another slide. So we can stop the antiviral vaccine 24 hours before giving the vaccine, and avoid using the antiviral drug for 14 days after vaccination. Influenza vaccine, contraindication, previous anaphylactic and the precaution, moderate and severe acute illness. We don't have a live vaccine of influenza. Patient with a bleeding disorder, risk of hematoma formation after injection, especially with the injected intramuscular injection, are often avoided. And if there is a choice to giving the vaccine subcutaneous for the vaccines that are given to the intramuscular, we can do that. Use a fine needle less than or equal to 23 gauge and make a firm pressure applied to the site without rubbing. Family instruction about the risk of hematoma, and this patient must be take their treatment before coming to give the vaccine. Immunoglobulin replacement and the vaccine, there is a list for the interval between the vaccines and the immunoglobulin. MMR and the varicella should be given more than 2 weeks before receipt of a blood product, or delay 3 to 10 months after receipt of the blood product, depend on the vaccine, and the list of the vaccine and the interval available on the CDC site. And this is the vaccine interval or selected travel. This is the list of the vaccine recommended for the selected tribe vaccine and the recommended age for each dose. This list also is available at the yellow box of the CDC. Summary: always assess the patient for any contraindication. Consider general contraindication, consider specific contraindication, and also we must keep the vaccine on the recommended temperature to keep its efficacy. Prevent exposed the vaccine for the temperature and also for the light if this vaccine is sensitive for light. All our information is available on a 2020 Yellow Book home at the CDC Travel Health, and the vaccine information statement also at the CDC. Thank you for your attention.
Thanks a lot, Dr. Safa. Vaccination always an area for question and discussion. Really, you provide a very informative and full of information lecture. Thank you for your effort to summarize this lecture for us in this nice presentation. May I ask the audience if you have any question for Dr. Safa? I'd like to thank especially Dr. Ali Sharif. MashaAllah, tabarakallah, very active and asking a lot of questions. Please compete with him regarding the asking question. Here there are
bio vaccine or polio vaccine?
Polio. I think we need polio vaccine.
That is, there is a memo was at 2019 during the outbreak on Philippines that the person who traveling to the Philippines must take a dose of injected polio vaccine, which is a killed vaccine.
The other question from Ahmed Hamid. Ahmed Hamid was asking what is the first choice. I think he was talking about your slide, Dr. Safa, regarding the MMR and BBD test, I think. Ahmed, am I right? If there is any question, please ask. Until Ahmed provide us with this question, I will provide this question. Laura Al-Gahtani asking when to give the hemophilus influenza. When to give influenza?
When what?
When to give H influenza? I think you mean hemophilus influenza. Laura Al-Gahtani.
Hemophilus influenza. It is we give it on the schedule, including on the a hexa vaccine, that is a vaccine with the essential vaccine for the children. And also there is some cases, but a separate Haemophilus influenza is available for some some cases which is had a contraindication for the combined vaccine like Hexa. If we separated all these vaccine, we can give DT separate and the other vaccine which is like hepatitis B and Haemophilus influenza for the children which cannot give him a Hexa vaccine.
Very clear, Doctora, very clear. Thank you. I will repeat this question, Doctor, for you from Ahmed Hamid. He is asking what is the first choice regarding you mentioned previously 3 options for the MMR vaccine and BBD test. He's asking what is the first choice?
The 3 option is equal, but that is according to the situation of the what happened. If the patient not giving any of them, we can give him on the same visit. And if the client come with taking MMR and need a BB test, now we must wait 2 weeks until we make a BB test. If he make a BB test first and wanted to take MMR, now we should take the second option. We wait 3 days until the result appear, and then we give the vaccine. Because the vaccine will give a false positive.
Yes, Doctor, you can complete. There is another question from Abdul Majid. Thank you for suggesting. Is there a vaccine in pill form, and how are vaccination realized in the country of arrival? How are vaccination taken in the country of arrival? There is a 3 questions in one.
I can't hear.
The first part. Is there a vaccine in pill form?
Pill form?
This is the question. In pill form. Pills.
مش واضح عندي السؤال.
Doctor, did you get our point? The question is there a vaccine in pill form? Pills. Or a pills?
Vaccine about what?
Doctor, the question and answer box arrives in front of you.
I open it.
Yes, there is question from Abdul Majid.
أنا عندي ماجد وأسامة.
Go to the end of the question and answer box.
Okay. Abdullah Al Hassan. Can mention the exact year that it is.
From Abdul Majid, is there any vaccine in pill form? I think you mean oral pills.
Oral what?
Oral pills, Doctora. PI.
Oral pills.
Yes.
Oral pills about the.
Is there any vaccine in oral pills?
Oral of typhoid vaccine.
Doctora, the question is there in a vaccine? He didn't mention any specific vaccine, but he mentioned is there in a vaccine in pill form?
There is a vaccine on a pill form, an oral. What is this?
Did you get the question, Dr. Safa?
About the typhoid vaccine. This is That is an oral pill for the typhoid vaccine, which is the live typhoid vaccine. That is the only vaccine which is pills. It is swallowed whole, not short.
Okay, great. Okay, the second part of the question is, and how are the vaccination realized in the country of arrival?
Realized?
Yes, how are the vaccination realized in the country of arrival?
Now we must register of the vaccine on the NVR, National Vaccine Record, which is on a Saha platform. These all the vaccine will appear on Sahati. For everyone have a Sahati on the phone and appear all the list of the vaccine which he has. And some cases, some country need a yellow card. احنا الان شغالين في الريكورد بتاعت الفاكسينات على الناشونال فاكسين ريكورد اللي هو السجل الوطني للتطعيمات على منصة الصحة. كل التطعيمة ما بتسجل فيه بتظهر للشخص على التليفون في برنامج صحاتي زي كوفيد بالضبط. زي ما احنا بنسجل كوفيد، اللقاحات التانية بتاعت السفر ممكن نسجلها وهتظهر في صحتي وهيبقى فيها نفس البروف بتاع الكوفيد يظهر للشخص.
Great, thank you, Dr. Safa. Thank you. Dr. Safa, you want to add any other thing?
No, thank you.
I think by this we will close the question at this point. Don't worry, inshallah, we will keep answering the question by the end of the day. But now we can proceed to the second lecture for the sake of time. It will be presented by, inshallah, Dr. Amna Rashidi. It will be about risk assessment during travel. If you have any question, as I mentioned for you, keep it and record it, and we will answer it, inshallah, later on. Thank you again, Dr. Safa.
Thank you.
دكتورة آمنة.
Yes. أيوة السلام عليكم.
عليكم السلام ورحمة الله وبركاته. دكتورة آمنة, you can proceed.
Yes. I cannot share the screen because I think Dr. Safa is still in.
Dr. Safa, can you stop slide sharing?
Okay, thank you. Bismillah ar-Rahman ar-Rahim. In the previous lecture, we discussed the importance of risk assessment as a main cornerstone of travel clinic. When you do travel clinic assessment, you will, as a provider and a traveler, will decide what is the correct plan and management for your patients. So today, in this lecture, we will talk about the traveler perception of risk. In risk assessment, depend on two main principles: the risk perception and the tolerance of that risk. Now, let's go to this lecture, discuss it thoroughly. In travel medicine is based on the concept of risk reduction. So what is risk? Risk refers to the possibility of harm occurring during the course of a trip. Usually when we are pronouncing risk, always you are thinking of about the hazard. So anyone can tell me what is the difference between risk and hazard? Can I have your answer, please? What is the difference between risk and hazard? Risk, as mentioned here, it is a possibility of harm occurring during the action. So What is hazard now?
Any participation?
Feel free to write any answer. This lecture is very important. It will decide the management plan for you and your for you as a practitioner to decide for your traveler the treatment. So when you do the risk, you will set the management. Any answers?
Yes, I have here a little answers. Hazard, any source of potential damage. There is a lot of answers here. Hazard is any source of potential damage. There is answer
Yes,
here.
excellent.
Yes, there is another answer here, Dr. Amna. Risk means that there are a chance or possibility. Hazard is a real damage that can happen.
Awesome. Yes. So the difference between risk and hazard, the hazard is the something that caused the harm, or as they said, the source of harm. Example, chemicals, noise, stress. But the risk is the chance or the possibility of any hazard to cause a harm. It is very important terms. What is the type of a traveler risk? Some risk may be avoidable, as we know, while other may not be. Let's take an example. For example, vaccine preventable disease is avoidable, may be mostly avoidable, depending on the protective efficacy of the vaccine. The perception of risk and tolerance. This is another terms which is very important for you as a provider. The perception of risk is a subjective evaluation, whether a risk is considered large or small. Let's take an example. Is 1 in 10,000 a large risk or a small risk? So it is a subjective evaluation. And this perception of risk is depend also on the tolerance. Tolerance refers to the acknowledging a risk and accepting it. A risk of 1 in 100,000 may be tolerable for one traveler, but not for another. To go in more details, travel medicine practitioners have felt that also statistic for a given risk could help them objectively advising a traveler about that risk. However, the rate of diseases means the statistic in a particular country or location, such as typhoid fever, malaria, or Japanese encephalitis, may not help a clinician or traveler determine the threshold for making a decision based on those statistics alone. So what more information we need? Additional information to help make an informed decision may include the length of travel, the type of a travel, and the proposed accommodation. This is very important information. Even when a risk is low, traveler decision will still reflect their perception and tolerance of risk. For more clarification, when told that the risk of Japanese encephalitis is only 1 in a million, so one traveler might reply to you, oh, then I guess I don't have to worry about it. While another traveler might say that one traveler will be me. So each traveler will have an idea about the risk, the benefits, the cost of vaccines, and the drug prophylaxis. And these should be discussed thoroughly in details with their clinician and travel clinic. And we know that the goal of the travel medicine should be to assess the risk for the traveler and to educate them, skillfully manage and minimize the risk rather than try to eliminate it. So travel medicine practitioner should discuss all available risk statistics and assess their client perception and tolerance of risk. And once this is done, the provider can then help the traveler find their individual comfort level when making decision about destination, activities, and prophylactic measure can be given to him. So, what is the pre-travel consultation? The pre-travel consultation offers a dedicated time to prepare a traveler for the health concern that might arise during their trip. The objective of this pre-travel consultation is to perform an individual risk assessment and to communicate to the traveler anticipated health risks, and then provide the risk management measures, including immunization, malaria prophylaxis, and other medication as indicated. And as you know, it is personalized. Each case is different than the other case. Even it is a family coming to you because one is child, the other is older. So this is very important management. Travel health advice should be personalized, highlighting the likely exposure and also reminding the traveler of risk, such as injury, foodborne and waterborne infection, vector-borne disease, respiratory tract infection, and bloodborne, and finally, sexually transmitted infection. And also all these will be discussed. We'll discuss some of them with our colleagues, and inshallah, the others will be after Salah and tomorrow, inshallah, in more details. So you have to have a component of your pre-travel consultation. And this component is the consultation itself and communicate this to your traveler. Effective pre-travel consultation require attention to the health background of the traveler and incorporate the itinerary step, duration, travel purpose, and activity of which determine the health risk. And we discussed this before. We said you have the patient plus the trip. So you have to have all the idea about the patient himself and about the trip. Then after that, you will determine the risks. After determine the risk, you will manage that. So in the pre-travel consultation, it is a major opportunity to educate the traveler about health risk at the destination and how to mitigate them. To go in more details about the risk assessment, there is a lot of information needed, and it's necessary to have it for your pre-travel consultation. So, past medical history about the patient, his age, gender, underlying condition, allergies, especially any pertaining to vaccines, X or latex, medication, others, special condition for your patient or traveler, the pregnancy, breastfeeding, disability or handicap, immunocompromised condition or medication, older age, psychiatric condition, seizures disease, and also recent diseases like cardiopulmonary or cerebrovascular event, Guillain-Barré, and severe allergies. Another important information needed to assess the risk, immunization history, routine vaccine, and the required vaccine for travel. Also, for your patient, you have to have information regarding prior travel experience, which include experience with malaria chemoprophylaxis. This is the first time he will take it, or he have experience before? Experience with altitude, illnesses related to prior travel. Then we will go to the other part, which is the trip details. The trip details, which assess the risk for your patient, is the itinerary itself, the country and specific region, including order of countries, if it is more than one country, rural or urban country. Why this is important to know it is a transient or it is direct? Because sometimes he will just move from country to another country, and that country required a yellow fever. So he cannot stop there without yellow fever. Even he will just sit for 2 or 3 hours. So this is very important information. Timing. For timing, trip duration. What is the trip duration? As Dr. Baber said, sometimes it's better at night or at daytime. So this is very important for the environmental hazards. Seasons of a travel, and this is very important also information. Time to departure. Also, very important information for the travel, the trip itself, the reason for this trip. Is it tourism? It is business, visiting a friend and relative, volunteer, missionary, maybe for education and research, maybe for adventure, seeking care, healthcare. And the other one is the travel style. Independent travel, or it is a package tour. Is it adventurous, or also the important one is the mood of that transportation. Another special activity, for example, this trip for disaster relief, for medical care, and if there is any high altitude, for example, or doing some special activity like diving or cruise ship, cycling, extreme sport, anticipated interaction with animals, or anticipated sexual encounters. This is very important to set the risk. Then you will manage these risks. The major step for management, of course, step one is assess the risk. Then communicate this risk as a two-way process between you and the traveler. Then manage that risk according, as we said, perception and according to tolerance of that traveler. And usually in our experience, and I think for your experience also, there is a major topic to be discussed with the traveler in travel clinic during a pre-travel consultation, mainly immunization. And Dr. Safa just now finished her wonderful lecture about immunization. And you have to review the immunization as well as those travel-related immunization for a specific itinerary and based on the travel medical history. Also, you have to discuss with your patient the indication for effectiveness of an adverse reaction to immunization. This is the main tips for this major topics for discussion. Other major topics during the pre-travel consultation is the malaria chemoprophylaxis. The malaria chemoprophylaxis is very important and to determine if there is a risk of malaria, and you have to discuss the personal protective measure. This is very important, and it's a common question from the patients. we will say, okay, I will take the tablet. So I'm going to safari, I'm going to the jungle. So no need to wear a long, clothes. So this is very important to be addressed with the patient. Discuss the risk and benefit of chemoprophylaxis and recommended choices of prophylaxis for the itinerary. Other important topics to be discussed with the patient in travel clinic is the vector-borne diseases. So you have to define the risk of disease in a specific itinerary and the insect precaution needed. Other important topics is the respiratory illnesses. You have to discuss area of particular concern. Nowadays we have the COVID-19 all over the world, and previously with the avian influenza in Asia or MERS in the Arabian Peninsula. Of course, consider influenza treatment for high-risk traveler. Travel diarrhea. And mashallah, Dr. Suwar just finished also 2 hours ago his great lecture about diarrhea. You have to recommend the strategy, recommended the strategy to decrease the risk of diarrhea. This is very important to discuss with your patients, and discuss the antibiotic for self-treatment. Also the attitude illnesses. This is very important also topic, and I think Dr. Baber also go through this important topic. And you have to determine if the itinerary puts the travel at risk of attitude illness. Discuss the preventive measures such as, like Dr. Baber said, the gradual ascent, adequate hydration, and medication to prevent and treat. Also, other environmental hazard, the caution the traveler to avoid contact with animal to reduce the potential for bites and scratch that can transmit rabies. Advise the traveler to avoid walking barefoot. Advise the traveler to avoid wading or swimming in the fresh water. Remind the traveler to apply sunscreen to skin exposed to sun. Other personal safety, which is another important topic to be discussed with your patients. Discuss the precaution traveler can take to minimize the risks, such as the traffic accident, alcohol excess, and personal assault. Also provide information on travel health and medical evacuation insurance. Advise the traveler to look for security related to their destination. Bloodborne pathogen, inform the traveler who will provide health care overseas, and we can see a lot of these travelers in our clinic. A lot of them are a healthcare worker to provide the healthcare overseas. What to do in case of needle stick or bloodborne pathogen exposure. Disease-specific counseling. Remind the traveler to keep medication and supply in a carry-on luggage, not to put it in their luggage in front of them. Advise the traveler to prepare for complication. If they have disease, maybe a complication may occur from underlying disease. Thank you. Any question related to this lecture?
Thank you a lot, Dr. Amina, for this interesting lecture about risk assessment. You exposed the topic from different perspective, and also you try to summarize also other speaker talk. Thanks a lot for this lecture. I will open the floor now for question. If you have any question, please feel free to ask. Any specific question for Dr. Amina? Dr. Amna, there is a question here. Is the bed infestation also included in travel health concern?
Sorry, the voice is not clear, Dr. Aurora. Can you repeat it? Your voice is not clear. Yeah.
Okay, sorry for that. Here there is a question. Is bed bug infestation also included in travel health concern? Bed bug infestation.
Yes, Doctor. Yes.
Included in travel health concern?
Yes, it is a concern.
Okay, Doctor. Is there any specific?
Sorry, your voice is not clear. I can hear Sada.
Please, the other tell me, my voice is clear for you or only for Dr. Amina? Dr. Amina, still the voice not clear?
Now it's clear.
Okay. I'm asking Dr. Amina, is there any specific recommendation or measures we have to follow them to avoid this bed infestation?
Yes, of course. This is very important, especially if you have to know this traveler is moving in a hot or moving in low resources countries and outdoors. So this is very important to give this information for your traveler. So this is very important, and we discussed this to understand where his accommodation will be. This is one. Second, the style of this trip, where will be? Is it on jungle? It is a safari. So he will be exposed more. And also if he going to low resource countries. This is very important. And to have the relevant to apply it in your skin. This is very important.
Great, thank you, Doctora. You answered the question. Is there any other question? Anyone want to add any question before going to the break? Please feel free to ask. We are inviting you to participate with us. Doctor, we will give them a couple of seconds if you allow me. And if there is no any question, then we can go out for a break.
Sure, Dr. Yes, we are live.
Please use the question and answer box to block your question. Till now, no question. For you, Doctora, I'm not till now no question. I think by this we can go now for a break. Inshallah, it will be for 45 minutes. And we will be around at 12:45 minutes, inshallah.
Inshallah. Thank you, Dr. Ra. Thank you.
Another mention for those who are asking about the attendance. The attendance, once you register online, your name is supposed to be registered. Okay, so we will depend on registration online, inshallah. The name will be raised through Mumaris, inshallah, to Saudi Commission, and supposed to get your hours, inshallah. And for the evaluation, inshallah, as I mentioned previously, you will get online link, inshallah, for the evaluation of the course. And we ask you please to participate in evaluation of the course. Thank you. And now you can go for your break, enjoy your break, and we will back, inshallah. We will be here, inshallah, at 12:45 minutes. Thank you. our respected audience and valued speaker. Welcome again to afternoon session in our travel clinic as a health service course. This morning lecture was shining light on the basic and fundamental of the travel clinic and travel-related disease and best way to prevent it happening. Now, inshallah, we will continue with our speaker for the afternoon session, inshallah. We will proceed with Dr. Babir, inshallah. He will talk about the sexually transmitted disease during travel and how to prevent it. Please proceed, Dr. Babir.
Assalamu alaikum. Is my slide visible, Doctora?
Yes, it is visible and your voice clear.
Thank you very much, Dr. Arwa. Bismillah ar-Rahman ar-Rahim. Welcome to all the participants back to our workshop after the prayer break. I must say, I must appreciate, along with Dr. Amna, that mashallah, there is a heavy participation, almost more than 3,000 people actively participating in this workshop, which is very, very encouraging for all of us. Alhamdulillah. We will start off with sexually transmitted infections, STI and travel. Sexual health is otherwise a major topic, a major concern all over the public health world. And it is a major issue concerning preventive medicine as well. Once we talk of travel health, travel clinic, it's absolutely impossible to ignore the importance and significance of sexual diseases. STIs are a major public health concern in both developed as well as developing countries. Sexually transmitted infections are very common and at the same time very costly to the public health and to the overall economy of any country. Travel health providers have a very important responsibility to educate their patients, their travelers about what they can do to reduce the chances of acquiring an STI during travel. You can see the slides, Dr.
Yes, the slide is clear. The slide is clear and your voice is pretty clear, Dr.
Okay. So I continue. Sexually transmitted infections, as I was saying, are very common and costly to the public health and economy of any country. Travel health providers, may it be any part of the world, including in Saudi Arabia, have a very important responsibility to educate their patients and travelers about what they can do to reduce the chances of acquiring STI during their travel. So what can we do as travel clinic physicians? Let us discuss this point now. What are sexually transmitted diseases? They are diseases that are mainly passed on from one person to another during sex. There are at least 30 different STI, sexually transmitted diseases, with a range of different symptoms. These diseases may be spread through any site of sex. It can be vaginal, anal, or oral. STIs are very common and serious problem worldwide, and most widely known STIs are gonorrhea, syphilis, and the HIV. Among them, the curable one are mostly the bacterial diseases, which include syphilis, chancroid, gonorrhea, chlamydia, trichomonas. And those which have serious problems are incurable, include HIV, AIDS, hepatitis B, genital herpes, and human papillomavirus. The epidemiology, as I discussed, STIs are spread all the world over, and the World Health Organization estimates that approximately 357 million infections with curable sexually transmitted pathogens, which include chlamydia, gonorrhea, trichomonas, and syphilis per year, or nearly 1 million new infections per day. This is really very, very high number, 1 million new infections of STI per day. More than 30 different sexually transmitted infections are caused by a range of pathogens, not all of which are curable or vaccine preventable. This is another major issue, that not all of them are curable, and unfortunately, we do not have vaccines for all of them. Global distribution of sexually transmitted pathogens and their sensitivity to available treatment varies. International travelers acquiring STIs from new partners while abroad serve as a conduit for spread of infections at home. Once they come back from their travel, and if they have these diseases, obviously they will pass it on at their home. Gonorrhea, for example, among the more common STIs globally, with an estimated 85 million new cases in 2012 only, has become extensively drug resistant in some parts of the world. Patients presenting with antimicrobial resistant gonococcal infections should prompt the healthcare providers to inquire about their travel history and the travel history of their sex partners. Before I move on here, I must add that continuation of my environmental lecture that I gave before, responsible behavior is very, very important. All the preventive measures, vaccines, prophylaxis, medicines, whatever we can prescribe to our traveler, the best thing he or she can do during the travel is to exercise responsible behavior. All these problems can be avoided if the traveler is given proper health education before he embarks on his travel, and he or she exercises responsible behavior. Distribution of STIs in general, the prevalence of STIs tends to be higher in urban areas than in rural areas. Obviously, it is understandable because urban areas have more population, different type of people. Rural areas are small, backward areas, and with the hi-fi life in urban areas all over the world, STIs are more common in urban areas, may it be developed part of the world or the developing world. The prevalence of these STIs is higher in unmarried people and in younger adults. Both prevalence and incidence are higher in the developing world than in the developed world. And that is why we see that most of the travelers would travel to developing countries, underdeveloped countries for this reason. In many developing countries, STIs have for several years ranked among the top 5 diseases for which adults seek health care services. Now, what are the factors that are associated with higher frequency of unprotected sex abroad? Generally, research has also supported this point that male are more prone towards sex once they are traveling abroad. Males, especially those males who are traveling alone, and the younger age group, starting from 25 to 45 years of age group, especially those traveling without their partners, either alone or with their friends. More than 2 sex partners in the last 2 years. Generally, if you ask them the history and if they are ready to share it with you in the travel clinic, this is what information they generally give. History of previous sexually transmitted infections would most likely be positive in these males. most likely they will be also involved in drugs or alcohol, or at least in tobacco use. And generally, if you ask them and if they share this information, there would be an expectation in these single males traveling abroad to have casual sex. And long-term travelers, those who are expatriates, military personnel, or who are working as volunteers in some peace mission. Sex tourism is also another, we can almost call it like an industry now. Sex tourism is travel specifically for the purposes of procuring sex. In one study, typical sex tourists were highly educated men, 30 to 40 years of age, going to economically disadvantaged countries to pay for sex with commercial sex workers. During the preparation of this workshop, we came across many studies, we consulted many studies, and the amazing point that we found in one of the studies was by Win Vikos et al. This was a study which was published in 2010 in the International Journal of Infectious Diseases, which concluded that 1 in 5 travelers, they had sex with a new partner while in a foreign country. Now, this was really a very astonishing figure, that 1 in 5 travelers had sex with a new partner while in a foreign country. And that is why we do see an exponential growth of reporting of cases of gonorrhea, syphilis, as well as HIV all over the world, and in this part of the world as well. Fewer than half of these men reported regularly using condoms, even in destinations where the prevalence of STI, including HIV, is high. In some countries, commercial sex work is legal and culturally acceptable as well. In many other places, however, sex tourism supports sex trafficking among the largest and most lucrative criminal industries in the world. I'll repeat my point again. Your behavior, the behavior of the traveler is what matters, number one. All these problems can be avoided if behavior is as per the normal norms. The way they behave in their home country in front of their families, if they would behave responsibly once they are alone in a different part of the world, will protect them from all these diseases. The extra and obvious link between STIs and HIV is behavioral. Unprotected sexual behavior exposes people to both HIV and STIs. As part of our experience working in the travel clinic, it's always better, especially youngsters, male, going to foreign countries, to give them very frank and clear-cut information that this is what you can expect if you get involved in such activities. But still, if this is your personal life, if still you have to get involved in such activities, no unprotected sexual behavior. They must use barrier protection. As I mentioned, 1 million new infections per day is what we are staring at. This is a huge problem all over the world. And as international travel restrictions will go down once COVID is coming under control, this number is even likely to increase. Now, what are the sexual health recommendations for travelers? If a traveler comes to us in a travel clinic, what should we advise him before he embarks or starts his travel? To obtain recommended vaccinations, including those that protect against sexually transmitted infections, get recommended tests for HIV and treatable STDs, be aware of STD symptoms in case any develop. The traveler should be advised to check the condom packaging and expiration dates, review local laws about sexual practices, and obtain contact information for medical and law enforcement services. If pregnant or considering pregnancy, review whether Zika virus infection is a risk at destination. My personal experience and in our department working here is that if you give very frank, clear-cut information to these young men, especially traveling abroad to countries like Thailand and Philippines and even some parts of Indonesia, this information goes down very well and there are better results. What can a traveler do during travel? Use good judgment in choosing consensual sexual adult sex partners. Use condoms consistently and correctly to decrease the risk of HIV and STDs. If indicated, be prepared to start taking medications for HIV post-exposure prophylaxis or unintended pregnancy within 72 hours after a high-risk sexual encounter. And obviously never engage in sex with a minor less than 18 years old, child pornography or trafficking activities in any country. One more point that I would like to highlight here as I move on with my lecture is that there should be no social taboo in discussing sexually transmitted infections. This is a serious problem for which, if I talk of Saudi Arabia Ministry of Health, is spending a lot of money on the treatment of these travelers. Why not give them the information before, in advance, that this is what they need to do and this is how they need to protect them?
Dr. Baber, your sound disappeared. We cannot hear you.
To decrease the prevalence of all-day working. What can
Dr. Baber?
To avoid exposing? Yes, please.
Dr. Baber, your sound is not clear. It disappeared.
Yes, it's showing here that the internet is unstable. I think it's. Is it okay now?
No, it's okay.
Now it's okay.
Yes.
Do you want me to repeat my previous two slides, or should I just carry on?
Please repeat the last slide only.
The last slide only. Okay. Yes, because this slide is very important. You know, during travel, what do we expect from a traveler during travel? I was mentioning, I think my sound was not clear, so I will make it clear again. There is no social taboo. Once a traveler comes to a travel clinic, very clear-cut information should be given to him regarding the prevention of sexually transmitted disease, just as information is given to him regarding the prevention of malaria and yellow fever. There should be no social taboo whatsoever. We are facing a lot of problems, lot of high prevalence of gonorrhea, syphilis, HIV all over the world, including in this part of the world. And that is why if a traveler comes to us, to the travel clinic, clear-cut guidelines should be given to him what to do and what not to do to stay away, to protect himself or herself from the STIs. So during travel, a good judgment in choosing consensual adult sex partners. Use condoms consistently and correctly to decrease the risk of HIV and other STDs. If indicated, be prepared to start taking medications for HIV post-exposure prophylaxis. Never engage in sex with a minor. By minor, I mean less than 18 years old. Child pornography or trafficking activities in any country. I'll move on. What should a traveler do after he has returned back to his home or his home country? To avoid exposing sex partners at home, see a clinician to get recommended tests for HIV and treatable STDs like gonorrhea and syphilis, checkroid, or any other. Now, coming back to the main issue that I've been emphasizing in my first lecture also, and I'll emphasize the same problem here. What are the ABCs to preventing STIs? Number one, A is for abstinence. Abstinence means stay away from consensual sex. Don't travel with the intention that, you're going with the intention of sex. Abstinence is the best way to protect. Tell the traveler very clearly, the best way to protect yourself from STDs is abstinence. B stands for be faithful to your partner, to your spouse. C stands for if still you have to do it, there is no other option that you have, then please use condoms. D, if you have not used condoms and then you have a problem, now you are feeling that there is problems, get diagnosed as soon as possible so that treatment can be started. And finally, E for education. The more you educate your youngsters, your people who are traveling normally to these countries, especially those going to Thailand, Philippines, should be given more and more education. I'm sorry to mention the name of these two countries. Sex can take place in any part of the world, but generally what we know from our experience is people returning back from these countries generally have problems which ultimately are diagnosed as cases of gonorrhea and syphilis, and even HIV. Relation between HIV and STI. There is increased incidence in transmission of HIV infection in presence of STIs, especially with ulceration, open sores in the genital area is much more likely to transmit HIV. Chancroid and syphilis are the main bacterial causes of sores. Vaginal infection with genital herpes also facilitates HIV transmission. What happens is generally is that an ulcer in the genital area will provide an open door through which HIV can easily pass. Now, if we talk about HIV infection is caused, the HIV is an enveloped positive strand RNA virus of the Retroviridae family. Transmission is through sexual contact. However, it can also take place through needles, syringe sharing, unsafe medical injection or blood transfusion, and organ or tissue transplantation. It can also be transmitted from mother to child during pregnancy, at birth, and postpartum through breastfeeding. However, most of the cases reported to us are those who give a history of sexual contact. Epidemiology, HIV every part of the world. Unfortunately, sub-Saharan Africa, as we all know, is the most affected part of the world. 25.5 million, internet is unstable. 25.5 million cases, or 69% of all people living with HIV infection, and the Eastern Europe and Central Asia region has experienced the largest increases in new HIV infections, 60% increase from 2010 to 2016. Although the reported adult HIV prevalence in many regions of the world is low, certain populations are disproportionately affected. Obviously, such as sex workers, the prevalence of HIV is, as understandable, more in sex workers, people who inject drugs, men who have sex with men, transgender people, and prisoners. So these are those segments of the population, of the public, in whom obviously the chances of having HIV are more. Sex workers are particularly vulnerable. The prevalence among sex workers is 12 times as high as in the general population. The risk of HIV infection for international travelers is generally low. Travelers' risk of HIV exposure and infection is determined less by geographic destination and more by the behavior in which they engage while traveling. I think I've been emphasizing on this point again and again. It does not matter you are going to which part of the world where prevalence is high or low. If your behavior is good, nothing will happen. Inshallah, you'll be fine. You'll come back healthy just as you went. So behavior such as unprotected sex and injection will have more problems. Travelers who might undergo scheduled or emergency medical procedures should be aware that HIV can be transmitted by unsafe, non-sterile medical injection practices, reusing needles, syringes, or single-dose medication vials. So this is another main issue. Those who are involved in drugs, those who are involved, who go from one country to another country for treatment, maybe for kidney transplant, maybe for some other issues, also need to be careful. The blood has to be properly screened. There are some parts of the world, as we know, screening of blood is not proper, and this can also be a major cause of transmission of HIV virus from one person to another. Dental treatment, let's not forget dental treatment. Dental treatment also, if the instruments are not properly sterilized, cleaned, this can also be a source of spread of infection. Clinical presentation, as many as 90% of people will recall experiencing symptoms during the acute phase of HIV infection. Acute HIV infection can present as an infectious mononucleosis-like or influenza-like syndrome but the clinical features are highly variable. Symptoms typically begin a median of 10 days after infection and can include fever, mucopapular rash, arthralgia, myalgia, malaise, lymphadenopathy, oral ulcers, pharyngitis, and weight loss. The patient or the traveler needs to be given information that if you feel any of these things that I've just mentioned, the symptoms, fever, weight loss, myalgia, arthralgia, pharyngitis, ulcers, especially oral ulcers, you need to be get examined as soon as possible. Diagnosis, as we all know, there is a rapid test for HIV as well. We have it available in all of our preventive departments in all the regions of the kingdom. Rapid test is almost 99.9% accurate, and it gives the results within 3 to 5 minutes. And it's available, readily available. Also in Arabic, I think we call it the Mashura program. And actively, we are all working on it. The confirmatory test, as we all know, is the Western blot. Treatment, prompt medical care and effective treatment with antiretrovirals can partially reverse HIV-induced damage to the immune system and prolong life as well. Effective treatment also substantially reduces the risk of HIV transmission to others. Prevention. Travelers can reduce the risk of HIV infection in multiple ways. They can avoid sexual encounters with people whose HIV status is unknown and use condoms consistently and correctly with all partners who are HIV infected or whose HIV status is unknown. They should also not inject drugs or share needles and avoid exposure to blood or blood products and non-sterile invasive medical equipment. Travelers who do inject drugs should only use sterile, single-use syringes and needles that are safely disposed of after every injection. What else can we do? There is something known as pre-exposure prophylaxis. Obviously, it's almost a medical term, but any traveler can be informed about it, can be given the health education about it, that pre-exposure prophylaxis with tenofovir. Tenofovir is highly effective in preventing HIV infection and is recommended as a prevention option for adults at substantial risk of HIV acquisition. Post-exposure prophylaxis with antiretroviral medications is another method to prevent HIV infection. Post-exposure prophylaxis is recommended as a prevention option for after a single high-risk exposure to HIV during sex, through sharing needles or syringes, or from a sexual assault. Post-exposure prophylaxis must be started within 72 hours of a possible exposure. This is very important because the more you delay it, lesser the possibility of getting the better results. Travelers who will be working in a medical setting, such as a nurse volunteer drawing blood or medical machinery performing surgeries, may have contact with HIV-infected or potentially infected biological materials. In certain settings, clinicians may prescribe PEP, post-exposure prophylaxis medications that a traveler could use in an emergency situation. HIV testing requirements for travelers entering foreign countries. Now, certain countries in the world, the international travelers should be advised that some countries screen incoming travelers, usually those with an extended stay. If it's just a transit stay or for a short while, maybe not. But if it's an extended stay, there are certain countries in the world who would like to screen the incoming travelers for HIV infection and may even deny entry to people with AIDS or evidence of HIV infection. People intending to visit a country for an extended stay should review that country's policies and requirements. Dr. Amna very clearly mentioned in the CDC website, you can go to the CDC website, enter the name of the country, and all information regarding all prevalent diseases of that country is available there. So for a potential traveler, it is better to visit the CDC website and go through the details of that country which he intends to visit. I thank you all for your patience. It was a long lecture, but I must say here that behavior. Responsible behavior is very, very important by any traveler, by any age group, male or female, especially male going to any part of the world. It does not matter where you are traveling. If your behavior as a traveler is a responsible one, I can assure you nothing will happen and you will stay away from all these STIs. Thank you very much.
Thanks a lot, Dr. Baber. Again, thanks a lot for raising this important topic. Actually, really, we need to raise awareness among STDs, among healthcare providers who are covering in travel clinic. So if we raise awareness, this will for sure improve the health provided for the patient. Unfortunately, STDs is still distributed, although we do this counseling clinic and عيادات المشورة distributed, but still it is one of the distributed problem. So thank you again for raising this issue. Hopefully the attendee get the benefit, inshallah, and it will help to improve their practice in the clinic. I think before we can tackle the question this time, I suggest we will proceed to the last lecture for today with Dr. Amna Rashid, inshallah. After that, we will open the floor, inshallah, for all questions you have. Dr. Amna, inshallah, will talk to us regarding the prophylaxis management during travel, and it will be the last lecture for today, inshallah. Dr. Amna, please take the lead.
Yes, yeah, no. Bismillah ar-Rahman ar-Rahim. In this lecture, we will cover the prophylaxis management during traveling and emphasizing on a major prophylactic treatment. What is a prophylaxis? Prophylaxis is defined as a process of guarding against the development of a specific diseases by a treatment or action that affect the pathogenesis, or the prophylactic measures guard against the disease by taking an action ahead of time, before happened, or in anticipation. Evaluation of a people before travel should include a review and provision of routine vaccine recommended based on age and other individual characteristics as type of a prophylaxis. Additional, some routine vaccine are recommended at early age for international traveler. Recommendation for specific vaccines related to travel will depend on itinerary, as we said before, duration of a travel, and the host factors. Vaccination against diphtheria, Haemophilus influenza type B, hepatitis A virus, hepatitis B virus, herpes zoster virus, influenza, measles, meningitis, pertussis, polio, and others are all routinely administered in Saudi Arabia as a routine vaccination. So let's talk about the vaccine in general and give some tips, some important tips on it. We know that Dr. Safa talked about a lot thoroughly about the immunization and vaccination separately. Now we will give you this important tips and major topic that you will discuss with your traveler or patient: the injection route and injection sites. This is very important, interesting terms. Injectable vaccine are administered by intramuscular, intradermal, and subcutaneous route. Route of administration are recommended by the manufacturers. Deviation from the recommended route of administration may reduce the vaccine efficacy or may increase the local adverse reaction. And this is sometimes happened in the clinic. Another important terms in the vaccine is the simultaneous administration. And this is very interesting term also, especially with COVID-19. And this is what we facing in our clinic. With some exception, all commonly used vaccine can safely and effectively be given simultaneously. That means on the same day, at a separate site without impairing antibody response or increasing the rate of adverse reaction. So it's a good information. This knowledge is particularly helpful for international travelers, for whom exposure to several infectious diseases might be imminent. Inactivated vaccine may be given at any time before or after a different inactivated vaccine or a live virus vaccine. Let's take one example or exception is the BCV 13 and the BCV 23. They should be administered 8 weeks apart. The immune response to an injected or intranasal live viruses vaccine, like MMR and varicella, might be impaired if administered within 28 days of a live virus vaccine. This is another interesting information and very important information, especially in the clinic. Maybe you can give multiple vaccines. And sometimes the patient will come to you, already he took a vaccine from other clinic. So typically the immune response is impaired only for the live viruses vaccine administered second. Whenever possible, injected or intranasal live viruses vaccine administered, the key point is on different days should be given equal or more than 28 days apart. No evidence exists that inactivated vaccine interfere with the immune response to yellow fever. And this is news. Therefore, inactivated vaccine can be administered either simultaneously or at any time before or after yellow fever vaccination. This is only a slide about the vaccination schedule for selected travel vaccine, giving the minimum age and minimum interval between the doses for the vaccine routinely recommended in the United States. And Dr. Safa go thoroughly on this topic. The vaccines and dose number for the cholera vaccine or the Japanese encephalitis or rabies, which is really these vaccines are rarely used. The typhoid and the yellow fever, the common one, can be used in travel clinic. Reporting adverse reaction. This is another important term for the vaccine to be emphasized on. The reporting adverse reaction after immunization. Adverse events after immunization have been reported with all vaccines, ranging from frequent, minor, local reaction to extremely rare severe systemic illnesses. For example, Yellow fever vaccine has generally mild adverse reaction like headache, muscle ache, and low-grade fever. Rarely people develop severe life-threatening reaction to yellow fever vaccine, such as difficulty in breathing or swallowing, swelling of the brain, spinal cord, or the surrounding tissue like encephalitis or meningitis. However, these serious side effects are very rare and very uncommon. Alhamdulillah, we didn't face like this, such cases, walillah alhamd, and inshallah, in the future, you and also us will not face this problem. Another topic for prophylaxis, we finish the vaccines and we go through the main tips for it. Now the chemoprophylaxis. And we will talk about a major chemoprophylaxis also used in travel clinic. The anti-malaria drugs. One of them is the anti-malaria drugs. When considering anti-malaria drug, their potential adverse effect must be weighed against the risk of acquiring malaria and the traveler access to prompt, reliable medical care. So the following questions must be addressed before you prescribing an anti-malaria drug. This important question is the traveler at risk of acquiring malaria? Are there any contraindication to use of a particular anti-malaria drug? Is the travel in an area with a drug-resistant Plasmodium falciparum malaria? And we said it is a big burden. It is a big public health problem all around the world. Will the traveler have access to reliable medical care in the event of symptoms of malaria occur? What is commonly used drug for malaria prophylaxis? The commonly that we use in our clinic is the chloroquine, #1. Prophylactic dose is 300 milligram weekly on the same day, each week. Begin 1 to 2 weeks before travel. Keep using during travel and 4 weeks after leaving endemic area. This is very important. And sometimes the patient will just miss the doses. This is very important. Chloroquine is the drug of choice for travel to area in which chloroquine resistant has not been prescribed or is minimal. Except for its bitter taste, it is usually well tolerated. And it may cause non-allergic generalized pruritus in individual of African descent. It is safe to use in pregnancy, and this is also a good news. Another side effect, mouth ulcer may occur in more than 1/3 of chloroquine users. This is an interesting epidemiological map about malaria endemic areas. And dividing the map, dividing the countries into color, green color country, which is the chloroquine sensitive malaria, red color countries with chloroquine resistant malaria, and yellow color countries with a multi-resistant malaria. Just to give you some information about these countries, the chloroquine sensitive malaria, which are in the green color, contain the Arabian Peninsula countries, Turkey, Egypt, Mexico, and Bolivia. While the chloroquine resistant malaria, which is equal to the red color, almost all Africa, except the north, and Pakistan, India, and Afghanistan, Yemen, and Oman. Multi-resistant malaria, as you can see here, with the yellow color, is confined to Burma, Thailand, Laos, and Cambodia. This is very important information, and you can keep it as a note with you for your information in the clinic. Mefloquine. The second choice is the mefloquine as a prophylaxis for anti-malaria drug. Mefloquine is effective in preventing malaria of all species. It will not prevent multi-drug resistant Plasmodium falciparum malaria. Both adults and children should take 1 dose of mefloquine per week, starting at least 2 weeks before traveling, and should continue for 4 weeks after leaving the endemic area. It is the same for the chloroquine. The weekly dose for adult is 250 milligram. For chloroquine, it was the 300 milligram. Regarding mefloquine, can be safely taken by pregnant women, which is a good news also, during all trimesters. Mefloquine. People with psychiatric condition, including depression and anxiety, psychosis, schizophrenia, should not take mefloquine. Adverse effects are for mefloquine, gastrointestinal upset, strange dreams, mood changes, insomnia, and headache. Other topic for chemoprophylaxis is the traveler diarrhea. Travel diarrhea is the most common illnesses in person traveling from resource-rich region of the world to resource-poor region. By formal criteria, it is characterized by 3 or more loose stool over a 24-hour period, accompanied by enteric symptoms such as fever, nausea, vomiting, and abdominal cramping. What is the chemoprophylaxis can be used for traveler diarrhea? There is antibiotic and non-antibiotic treatment. The non-antibiotic treatment, prophylaxis, such as bismuth, subsalicylate containing formulation, Pepto-Bismol, has proven very, very effective in preventing traveler diarrhea. The bismuth subsalicylate in tablet or in a liquid form has afforded 62% to 65% protective efficacy against traveler's diarrhea. Black tongue and stool caused by the formation of insoluble bismuth salt may occur for the patients. Other chemoprophylaxis for diarrhea is the fluoroquinolones. Fluoroquinolones afforded 84% protection in a multiple chemoprophylaxis studies, which is very interesting. Their efficacy may be lower in regions of the world such as Southeast Asia and India. Why? Because a fluoroquinolone resistant is on the rise. If you prescribe chemoprophylaxis, should be recommended for diarrhea no more than 2 to 3 weeks. And when considering chemoprophylaxis, fluoroquinolone antibiotic remain the first of choice. Antibiotics are effective in the treatment. Now we move to the next part for the diarrhea treatment. The antibiotics are effective in the treatment of the traveler diarrhea and can reduce the average duration of disease from several days to 1 day. And fluoroquinolone remain predictably active for empiric therapy in most parts of the world and remain the drug of first choice. Another antibiotic used for treatment of diarrhea azithromycin. Azithromycin is effective against Campylobacter species, as well as against the broad range of bacterial pathogens that cause a traveler diarrhea. And the good news here, azithromycin is safe to use in children and pregnant women. Moving to another topic regarding the chemoprophylaxis using in high altitude. Acetazolamide. Acetazolamide is a carbonic anhydrase inhibitor that may facilitate acclimatization by increasing ventilation, particularly at night. And this will increase the bicarbonate diuresis following the respiratory alkalosis at altitude and increasing the arterial oxygen level. Although there is no agreement on the optimal doses, the accepted dose for acetazolamide is 125 to 250 milligram twice daily. Begin 1 day before ascent and continue for at least 2 days at the highest altitude. So this is very important to know the style of the trip. Dexamethasone. For high altitude, the dexamethasone should usually be reserved for treatment of severe cases of altitude illnesses. And the dexamethasone dose is 4 milligram twice daily. Thank you very much. For this, we end for this lecture, at the end of this lecture, to give you a summary about our today lectures. We discuss the travel, clinic, policy and the procedure, and the risk assessment, how to do it, how to manage it, the prophylaxis, how to choose the drug of choice of these, the risk, how to choose the right and the correct prophylaxis for the risk. And we go in deep and travel environmental hazard and personal safety, as well as the vaccination and special diseases like travel diarrhea and sexually transmitted diseases. Thank you all for your patience and active participation in our workshop. And tomorrow, inshallah, we will continue in more specific topics like malaria, yellow fever, meningitis, pregnancy, and airborne diseases, and especially COVID-19 as a big common topic nowadays for travel. Thank you.
Thanks a lot, Dr. Amna, for providing such great closing lecture, which address and answer a lot of questions regarding chemoprophylaxis during travel, and also you summarize the whole lecture for today. Really, thank you for this great lecture. Now, I think we will open, inshallah, the floor for.
Thank you, Dr. Aroa. Thank you very much.
Welcome, Dr. Amina. Welcome, Dr. Amina. Now, inshallah, we will open the floor, inshallah, for a question which is related to the course. Please, if you have any question, write it in the question and answer box. Here I have approximately a couple of questions. I will start with them until the other provide the question. The first one is for Dr. Safa. Is there any contraindication to if there is any contraindication to vaccination? Can we use immunoglobulin instead of vaccination? Dr. Amina or Dr. Babir, if you want to ask, please feel free to answer.
Yes, I can add please here. Dr. Safa is, I think, not around. Immunoglobulins generally for travelers, we are not giving, frankly speaking, with our experience that we have in Jubail at least. However, in case of emergency, especially in case of hepatitis B, or in case of any other rare disease, we can use it. But generally, the answer would be no. I mean, basically, we are just relying on vaccines. Vaccines like yellow fever, like Dr. Amna mentioned, the most common one that we are using. So the answer to the question would be no. However, if there is exposure, and as we know for hepatitis B, as soon as possible, immunoglobulins should be used. So they can be used, but generally in travel clinic, no, we are not using immunoglobulins.
Thank you, Dr. Baber. Thanks a lot. The second question is, what is the year of addition of hepatitis A vaccine to Saudi Arabia routine vaccination schedule?
Sorry, can you repeat again? What about hepatitis A vaccine, Dr. Arwa? Alish?
What is the year for addition of hepatitis A vaccine to Saudi Arabia routine schedule?
For the routine schedule, it is given at 1.5 and 2 years of age.
Okay. I think that you answered the question. They are asking about the year. Okay. The third question, why gonorrhea infection from STDs has the most important bacterial resistance?
Why it is the most important? Because it is
most resistant.
Yes.
Why gonorrhea infection among the other STDs has most bacterial resistance?
It is most resistant in some parts of the world, Dr. This is what I meant. I mean, not in every part of the world, but in certain parts of the world, yes, it is highly resistant because it is more prevalent, and because of the misuse of antibiotics, not completing the course prescribed by the doctors, leaving the medication in between. These are the reasons why it is becoming more and more resistant in some parts of the world, indeed.
Great. Thank you, Doctor. After that, I have another question asking about human papilloma virus vaccine. Can we use it in the treatment, not only in the protection against genital warts?
For genital warts, Doctor, you are asking about vaccine?
Human papilloma virus vaccine. The question is, can we use the human papilloma virus vaccine?
Malish, Dr. Arwa, your voice is not very clear, please. Can you just repeat the question? I don't know. It's not audible. It's not...
Is it
no
clear
problem,
now?
Please.
Is it clear now?
Yes, now it is better. Yes, it is better now. Please, go ahead.
Okay, good. The question is about human papilloma virus vaccine. Can be used in the treatment of genital warts, not only for protection.
No, generally, as we know now, it has been used only for protection, not as a treatment for warts. Warts has a totally different treatment regimen, and HPV vaccine is not generally used for the treatment of genital warts. Only as a prevention.
Okay. Good. The second question also related to sexually transmitted disease. So
yes, please.
Is it visible every time for a tourist who visit a high risk area, for example, area with HIV infection, to be tested with every visit?
It only depends, Doctora, upon the behavior of the patient. If the patient comes to our travel clinic and gives us a history that yes, he has been involved in any such activity, I would immediately recommend doing the rapid test for HIV and screening him for other STIs also. But if there is no such history, and the patient, the traveler is very frank with me that I have not been involved in any such activity, I would not recommend such a test for him. But other than that, having said that, as I mentioned in my lecture also, that now we have the rapid kit for HIV available in all of the preventive medicine departments throughout the kingdom. There is no harm in getting screened.
Great. Thank you, Dr. Robert, for this information.
Welcome, Dr.
The second question will be for Dr. Amina. Dr. Amina, one of the audience asked, what is the recommendation when missing the weekly dose of chloroquine? Is chemoprophylaxis dose differ from the treatment dose? There is two questions in one.
Yeah, for the chemoprophylaxis, sometimes they will miss 1 to 2 days. 1 to 2 days will not affect the regimen of the disease, of the prophylaxis treatment. But if they increase the days, they should start the regimen again.
Okay, great. Thank you, Doctora. Doctora, can you repeat the answer, please? Your voice is cut down.
Yes. For the anti-malaria prophylaxis, if they just have 1 to 2 days missed the dose, they can continue their regimen. But if they extend these days, so the concentration of the drugs will be decreases. So they have to continue, and they have to start every week two tablets during the travel.
Great. I think you answered this question, Victoria. Another question also for you.
Yes.
Fluoroquinolone prophylaxis in patients with hemolytic anemia not accepted. Is there any way of prophylaxis against malaria in these patients?
Fluoroquinolone what?
Prophylaxis in patients with hemolytic anemia is not accepted. Is there
Yes.
any way of prophylaxis?
Mifloquine. The other choice is the mifloquine.
Great. Doctor, there is a question from Ahmed Abdullah. Is it true that quinine group, which is anti-malaria, can affect kidney or cause kidney failure?
Kidney failure, no.
Another question, if you allow me, Dr. Amna.
Yeah, sure.
Does the kids from 8 to 10 years old still can get the routine vaccination? I think he's asking about the catch-up vaccine.
Asking about what? I cannot get it, Doctora. Please, can you repeat it?
He's asking, does the kids from 8 to 10 years old still can get the routine vaccination?
Kids, children from 8 to 10 years of old. Okay.
Can he can get the routine vaccination?
Sure.
Great.
He means they are a defaulter, for example?
Sorry, Doctora?
A defaulter from the vaccination. We can give them the routine vaccine, and we can reschedule these patients.
Please, who sent this question, if the Dr. Amna answer you, it's okay. If it doesn't answer you clearly, you can repeat your question. Okay, I have a question. Okay, Doctor, the last question. What is the rationale behind taking single dose of intramuscular erythrometer anti-malaria drug few days to travel? I heard about it some time ago.
Can you repeat it? What is it?
Intramuscular? Yes, what is the rationale behind taking single dose intramuscular artemether anti-malaria drug few days to travel?
Actually, we are not using the intramuscular anti-malaria drug here. We are using tablet.
Okay.
Yes.
Okay, Doctor, is there anything like this in other places, if you have any idea?
No, sorry. I don't have any idea regarding this one. In the kingdom, especially. And even in the CDC.
Okay, there is also another question. The audience ask, هل زيارة الفلبين تستدعي أخذ لقاح الحمى الصفراء أو visiting Philippines require taking the yellow fever vaccine?
Yes, this is very interesting questions, and we will cover it tomorrow. But because he's asking now, the Philippines now required the yellow fever card or the yellow card. It's not the yellow fever vaccination. What we know that there is a for a traveler who visits a country endemic with yellow fever vaccine. So we have to give him a yellow book. Nowadays, Philippines have set policies that any traveler from Saudi Arabia or any other countries, they should confirm that they have the COVID-19 vaccines, not the yellow fever vaccine. So we have to confirm it in the yellow book. Now we call it as a yellow book, or a yellow card, not a yellow fever vaccine card.
Great, great. Thank you, Dr. Amna. I think this was the last question. I cannot see another question here. Sorry, there is another question for you.
Yeah, sure.
Does malaria drug effective for baby who have parents coming from epidemic area? He was pointing in case A.
Yeah, we can give it to children. We can give it to the families or parents once they are going to travel to endemic areas. Why not? If the risk is there, you can give chemoprophylaxis for the area, for children or for adults.
Great. Doctor, there is a previous question. I think he is asking about the catch-up vaccine. He wrote here, what I mean, Doctora, when the kid's age is from 1 to 5 years old, they didn't get the vaccine only after birth. Now the kid's age is 8 to 10 years
Yes.
old. Do they still can get those vaccines?
Sure, yeah. So they are a defaulter from the vaccines. So they have to be rescheduled again. He means that only they took a vaccine for 2 months or at birth, which is the hepatitis B. So all these vaccines didn't taken by these children. So we have to reschedule them again. Nearest PHC can reschedule them and give them all the routine vaccine which is available and can be given to their age group.
Okay, thanks a lot, Dr. Amina, for your great patience.
Most welcome.
Great response.
Thank you for you, Doctor.
I think by this question, we will close the session for today. Hopefully, my dear and great audience and the speaker you will enjoy with us today. Inshallah, as the Dr. Amna mentioned, we will be tomorrow together at 8:30 a.m. Inshallah, we'll start. Hopefully, you will join us again. And now I hope for you a wonderful day and night from now, inshallah. Thank you.